Good evening, I'm Dr. Mounika. My poster is Atypical Orbital Apex Syndrome secondary to intracranial suprasellar mass lesion, a rare case report. Orbital apex is anatomically a posterior part of orbit where orbital walls converge. The orbital apex incorporates optic canal, superior orbital fissure containing optic nerve, and all the structures passing through the superior orbital fissure, 346 nerves, etc. Various etiological factors like inflammatory, infectious, neoplastic, traumatic, vascular causes can also involve orbital apex, leading to orbital apex syndrome. Atypical orbital apex syndrome is one which presents with individual cranial nerve palsies, bilateral optic nerve involvement due to anterior chiasm lesion. Case report: a young female 29 years presented with drooping of upper eyelid since 3 months, defective vision since 4 months, and headache since 3 years with restricted ocular movements except abduction in left eye. On examination, left eye exotropia 15 degrees, limitation of adduction, elevation, depression, dextro elevation, and dextro depression is present. Right eye normal ocular movements. On examination, right eye visual acuity is 612 with pinhole no improvement. Other anterior segment findings are within normal limits. Left eye visual acuity PL plus PR present in all quadrants with moderate ptosis and pupil mid dilated and fixed. Remaining anterior segment findings are within normal limits. Ptosis examination: left eye MRD1 is 2 mm, MRD2 is 5 mm, palpebral fissure height is 7 mm. Bell's phenomenon is absent. Fatigability test and ice pack test were negative. Fundus examination: right eye media is clear, optic disc temporal pallor present, margins well defined, cup disc ratio is 0.3:1, vessels normal, macula FR plus and peripheral retina is normal. Left eye media is clear, optic disc diffuse pallor present, margins well defined, cup disc ratio 0.3:1, vessels normal, macula FR plus and peripheral retina is normal. On visual field analysis 30-2, visual vertical defect is seen in right eye. MRI brain and orbits shows well-defined T1, T2 heterogeneous hyperintense solid cystic mass in suprasellar region with hemorrhagic component within it, suggestive of craniopharyngioma or germinoma. Clinical diagnosis: atypical orbital apex syndrome presenting as oculomotor palsy, left eye with bilateral optic atrophy, secondary to intracranial suprasellar mass lesion. Discussion: atypical orbital apex syndrome presents with involvement of any of the cranial nerves passing through the superior orbital fissure and optic nerve. Extension intracranially presents with atypical features like involvement of anterior chiasm presenting as bilateral optic atrophy. In this case, the patient presented with severe loss of vision in left eye with third nerve palsy and bilateral optic atrophy, sparing fourth and sixth cranial nerves. It leads to atypical presentation of orbital apex syndrome. Conclusion: this case highlights the importance of evaluation of oculomotor palsies with fundus examination and neuroimaging, which reveals mass lesions involving the anterior chiasm, which is challenging for neurosurgical management. Early diagnosis of atypical orbital apex syndrome and proper management by ophthalmologist and neurosurgeon will help to save the patient going into total optic atrophy and management of other complications secondary to intracranial mass lesion. Thank you.